Hi everybody, welcome to tonight's webinar. Vet Education is proud to present a free webinar on intravenous lipid emulsion therapy in small animal toxicology, kind of subtitled, Where Are We Now? Thank you so much for coming along for tonight's lecture. This lecture has actually been brought to you by a 4-week online course called Venoms and Toxins in Small Animal Practice. You can check out the details at veteducation.com.au, but it's a 4-week online course. It's being written, this one, specifically for veterinary nurses and technicians. But if you're a veterinarian and you want a refresher, there's tons and tons of stuff in this course for you, and we will provide you with some extra papers and things as well if you would like them. It is race approved for 20 CPD points. There are loads of practice protocols in there, tutorials. There's an extensive course ebook in there as well. If you register before the course starts, you will get some free infographics. There's also a free ebook that I've been working on for sedatives for toxicity patients. And you'll get not only the recording of this lecture, but a recording that you can download as well. So thank you, Venoms and Toxins in Small Animal Practice, for sponsoring this free lecture. My name's Philip from Vet Education. I graduated a long time ago. I'm an old person, relatively old. I've been doing emergency medicine now for 24 years. I did a residency at the University of Melbourne many years ago, gained membership of the Australian New Zealand College of Veterinary Scientists in Veterinary Emergency and Critical Care, as well as Medicine of Dogs, and did a Master of Veterinary Studies during that time as well. I'm published in snake envenomation, in refereed literature, and one of the areas of my passion in emergency medicine is small animal toxicology and toxinology, the study of toxins and their behavior in animals as well. So this lecture kind of fits in well with that. That's enough about me. Let's find out about intravenous lipid emulsion therapy. I see that some of you in the chat beforehand, before the start of this lecture, we're just typing in what you've used intravenous lipid emulsion therapy for. And there was a lot of talk about it in small animal toxicology circles. But essentially what it is, it's administration of a sterile emulsion of soybean oil in water. Okay, so yes, there's some olive oil, triglycerides in there as well, some egg phospholipids and glycerol. Most of the time we're using this solution that you see on the screen here, intralipid. Different name depending on whatever country you are in as well, but it's basically intralipid that we're using, and this is the broad composition of this lipid. So why do we use it? Well, it's been found to be a novel antidote in human toxicology and increasingly in veterinary toxicology as well. It was first used in 2006 to manage cardiac arrest secondary to an accidental overdose of bupivacaine in a human being, and they managed to resuscitate that human being, which is great news. And since then it's been used in both treatment of toxicities caused by both lipophilic and non-lipophilic toxicoses with varying degrees of success. Even some highly lipophilic drugs can have moderate amounts of success in terms of improvement in patients' clinical signs, and patients with non-lipophilic drugs have been found to have quite a good response to the administration of intravenous lipid emulsion therapy. So, you know, begs the question, how does it actually work? And we'll get to this in a couple of slides time, but you can get intralipid or intravenous lipid emulsion in 10%, 20%, and 30% solutions. The one that we most commonly aim to use is a 20% solution, simply because we can use a smaller volume of it, and we'll talk a little bit more about that when we talk about some potential complications. For patients with marked or severe toxicosis that may be responsive to intravenous lipid emulsion therapy, you could potentially consider using 30% intravenous lipid emulsion solutions to enable you to give smaller volumes to your patients. The dose that we typically give, and it's a fairly empirical dose that we're giving in canine and feline patients right now, is about 1.5 mils per kilo as an intravenous bolus. We give that over Look, in the literature, it's anywhere between, you can get 1.5 ml per kilo bolus over 5 minutes up to 20 minutes or so. So depending on how brave you are and how sick your patient is and the sort of toxicity that they have, normally when I'm administering intravenous lipid emulsion therapy, I'm administering that 1.5 ml per kilo bolus over about 10 to 15 minutes. All right. And that's simply because while this is a small volume that we're giving to a patient, 1.5 mils per kilo, the osmotic pool or oncotic pool that these lipids actually have can cause a transitory hypervolemia, particularly in susceptible patients. So if you're dealing with a cat, for example, you may want to give that intravenous lipid bolus probably over about 15 to 20 minutes. Once you've done that, we generally give a continuous infusion of 0.025 mils per kilo per minute, which is about 1.5 mils per kilo per hour, for anywhere between 30 minutes up to 120 minutes. And you can repeat that if the patient's clinical signs improve and then get worse, or your patient's clinical signs have not improved as much as you would like them to. You can repeat this bolus about every 4 to 6 hours, as long as your patient has not got lipemia, okay? Because lipemia, clearly we're using an intravenous lipid emulsion therapy. Lipemia is a problem for our patients, and lipid emboli is certainly one of the known risk factors for patients, and we obviously want to avoid that if possible. So generally we're taking a blood sample just to spin it down for a packed cell volume total protein and assessing whether or not our patient is lipemic before we give them subsequent doses. The maximum dose that is recommended is around 8 mils per kilo in a 24-hour period. So how does it actually work? Well, the traditional theory was that we were giving our patients an intravenous form of lipid, and that anything that was lipid soluble would be soluble within this lipid compartment that we had created. And so any circulating drug would be bound by the intravenous lipid, and then it would be removed from circulation or excreted. So this binding of or dissolving of lipophilic drugs within this lipid removed them from the aqueous plasma, and that just reduced the amount of free drug that was available to bind to receptor sites and cause toxicity. And that seems like a pretty reasonable theory. The new paradigm is that there are a couple of, headings in which we try to categorize our thinking when it comes to intravenous lipids. The first is very similar to the lipid sink theory. We like to call this now scavenging effects of intravenous lipid, where the intravenous lipid acts as a not so much as a sink, but more a dynamic shuttle. So it will definitely dissolve or lead to the lipophilic medications becoming a part of this intravenous lipid compartment. So the lipid scavenges the drug from areas of high blood flow areas like the heart and the brain, and redistributes them to muscle where it's stored, or to the liver where it's metabolized. Okay, so what we generally have is this scavenging effect. The intravenous lipid scavenges this drug from high blood flow areas. I think that might means high. Actually, that's my typo. My apologies. The high blood flow areas like the heart and the brain, and redistributes that drug elsewhere in the body. And that kind of makes sense, because if we give intravenous lipid, it's not just going to stay in the blood vessels, is it? It's going to redistribute out throughout our patient's circulation. So this is the way we think of it now, is rather than just a sink that scavenges all of this drug and that's where it stays, it actually then carries it around the body and redistributes it where it is stored, or where it can be metabolized in the liver. There are some non-scavenging effects of intravenous lipid emulsion therapy as well, and these have most thoroughly been described with local anesthesia toxicity, so bupivacaine or lidocaine or lignocaine toxicity. But one of the non-scavenging effects is, I mentioned before about blood volume expansion. All right, so when we give a bolus of intravenous fluids, we intravenous lipids rather, we get an increase in blood volume, and that increases preload in the heart and has a non-specific side effect of increasing cardiac output. Because we stretch the myocytes, we get a much stronger contraction in systole than we do without preload expansion. So that mild preload expansion can help improving cardiac output. We can also get lipid-induced alterations in nitric oxide signaling, which can increase vascular tone. So this is particularly of importance in medications that cause hypotension, for example. Intravenous lipid may minimize reperfusion injury. The exact mechanisms of that are not entirely clear, but it does seem to reduce oxidation of cell membranes. There's also a calcium-mediated positive inotropism as well that occurs due to the uptake of lipid into cardiac myocytes. Along with calcium, we get a positive inotropic effect there as well, and as well as free fatty acid energy supply to myocytes as well. So that's really how it works. Just a quick reminder that this lecture is being brought to you by the Venoms and Toxins in Small Animal Practice course that is being brought to you by us here at Vet Education. So please visit the website veteducation.com.au if you want to check out some more information about the contents of that course. And as asked the question, does the increase in blood volume increase the risk of increased intracranial pressure? That's a really interesting one, Anna, because I guess in some instances, if you already have a patient that has increased intracranial pressure because they have a central nervous system toxin, I'm thinking like permethrin toxicity, those sorts of patients who may have increased central nervous system excitation, the administration of intravenous lipid emulsion therapy, particularly that initial bolus, could temporarily increase the systolic arterial blood pressure. Monitoring blood pressure is really key there. So our aim whenever we are managing a patient with central nervous system dysfunction is to have systolic arterial blood pressure somewhere between 100 and 120 millimeters of mercury. If it goes much above 140 to 150 millimeters of mercury, if we have disruption to cerebral perfusion autoregulation, which can occur if you've got a patient who's extremely obtunded, a patient who has status epilepticus, for example, as a result of some of the toxin that they've had, then that could potentially raise intracranial pressure in those patients. So in those patients, perhaps administering that initial intravenous bolus a little more slowly could be well worthwhile. And as I mentioned when I talked about those doses, they are fairly empirical, the doses, as are the times that you're supposed to administer them. And so I think that we still have a lot to learn as veterinarians, and I think in the human field they do as well, about the rate at which we should be administering these medications, and perhaps even the dose that we should be administering in patients as well. But you do raise a really good point. The upshot of what I've just talked about is to look at your patient before you're giving the medication. If they already have signs of pinpoint pupils and they've got decreased responsiveness, then you should do as much as you possibly can to reduce intracranial pressure. That is giving oxygen therapy to your patient, giving intravenous fluid therapy, and providing supportive care to your patient so that systolic arterial pressure is around about that 100 to 120 millimeters of mercury. Get a blood gas if you can, and if you have elevated carbon dioxide concentrations or decreased oxygen concentrations, then intubating that patient and ventilating that patient, even if it's just until you get control of that central nervous system excitation, are the things that I would be doing first before I considered giving intravenous lipid emulsion therapy. So I think there's a lot that and the other thing is obviously giving drugs like mannitol plus or minus furosemide to reduce the patient's intracranial pressure before you then go ahead and administer your patients with intravenous lipid emulsion therapy. So hopefully that is a helpful answer. Do I recommend a central line? No, not for administration of the intravenous lipid. And What about blood pressure monitoring? Do I use a central line to administer blood pressure, to monitor blood pressure and central venous pressure? The answer to that question is no. And I'll tell you the reason why, and that is that the accuracy of central venous pressure for measuring blood pressure, central venous pressure, is around 50%. So we have no idea if it's an accurate reading or not. So central venous pressure, really, there's not much point in doing it based on what we know in human medicine. Veterinary medicine, we haven't got a lot of details on it, but certainly the use of central venous pressure is inherently unreliable. Now, the use of mannitol and furosemide in a patient with increased intracranial pressure, I'll only use that if I have given my patient oxygen therapy, they have a patent airway, and they're breathing properly, and I've got some idea as to whether or not they require ventilation support. If they do require ventilation support, then I'll ventilate them to decrease carbon dioxide concentrations and increase oxygen concentrations as well in circulation. And those two things are going to lead to decreasing intracranial pressure in my patient that has, pinpoint poorly responsive pupils or dilated poorly responsive pupils. If my patient has normal CO2 and normal oxygen concentration on a blood gas and they have evidence of increased intracranial pressure, then I'll go ahead and give mannitol to those patients. I say plus or minus furosemide. Furosemide's a venodilator, so you might get a bit of increase in venous capacitance, and that might help as well. Hopefully that answers your questions okay. So when can we use intravenous lipid emulsion therapy? And what I did when I was writing this lecture and the blog, and if you haven't got notes, if you scroll right to the top of the chat there, I put a link to the blog, which is on the veteducation.com.au website, and I'm hoping that Danielle will post that link again for you around about now. There she is. Thank you, Danielle. When I was writing this lecture, I went through all of the veterinary literature from the past 12 years and looked at every single case report, case series, retrospective study as it applied to the use of intravenous lipid emulsion therapy in dogs and cats to try to find out what we know, when it's worked, and also to examine the quality of the evidence that we have. Because when you're relying on case reports and case series, it's natural for anyone to have a case. I administer a drug, I get a good response, I'm going to write it up because it's really exciting. I might have found something new, and this is how we accumulate lots of data in the literature, and that's brilliant. But the quality of the evidence is a little lower because there's an inherent bias there. If I have had maybe a patient with the same drug toxicity and I've given intravenous lipid emulsion therapy and I don't get such a good response, I may not write that one up, but I might write the one in which I've got a good response. So we kind of get a skewed view of how these things work and how well they work, and we get an incomplete view of how well intravenous lipid emulsion therapy works. So bear with me, we're going to run through a whole bunch of drugs and have a look at what we know about them. So amlodipine, it's recommended for amlodipine toxicity in dogs and cats, and this has come from people, but in veterinary medicine we have a case report of a 4-month-old male and tired dog that accidentally ate its owner's amlodipine tablet. Clinical signs: tachycardia, hypotension, and hyperlactatemia. The dog was treated with intravenous fluids and was given intravenous lipid emulsion due to poor response to IV fluids and an increase in the patient's blood pressure. And what happened was they had a rapid improvement in this dog's blood pressure by the end of the infusion, and the heart rate came down. So the heart rate came down and the blood pressure normalized. So, on the basis of this one case report, we have a recommendation that maybe this could be helpful for amlodipine toxicity. Let's look at amphetamines. There's a case report of a dog, a singular dog, that ingested a potentially lethal dose of Adderall, extended release amphetamine. There was a significant decrease in both serum and plasma amphetamines following the intravenous lipid emulsion therapy. No other treatments were given. The dog had a good recovery and it was discharged within 24 hours. So again, amphetamines and certainly the experience in human medicine suggests that that intravenous lipid emulsion therapy may be really helpful for management of methamphetamine overdose or toxicity in dogs as well. What about bromethylene? So it's CNS toxin that is now sort of almost taken the place in a lot of areas of the world, taken the place of a lot of the anticoagulant rodenticides, and we now have this, for which there was an antidote, as in vitamin K, and now we're left with this horrible drug bromethylene, which is a central nervous system toxin. There's a case report of a 4-year-old female spayed dog with witnessed bromethylene ingestion. She had unsuccessful emesis. She had intralipid therapy administered, and serum bromethylene levels were measured both before and 1 hour following intravenous lipid therapy. She did have some other treatments as well with activated charcoal, that's what the AC stands for, and some fluid therapy, and she had significantly decreased concentrations of bromethylene in the blood following her intravenous lipid emulsion therapy. So this is great news for the treatment of this pretty awful toxin of bromethylene. There was another case report as well of a 12-year-old female entire dog. She presented with lethargy and vomiting. She had IV fluids, famotidine, meropitant, buprenorphine. She deteriorated. She had a modified Glasgow coma score of 8, so she had severe central nervous system depression. She received mannitol and enema to try to get gastrointestinal decontamination, and she had intravenous lipid administered 24 hours after intoxication. So this dog had lots of supportive care for 24 hours before she received intravenous lipid emulsion therapy. Basically, she received the intravenous lipid emulsion therapy because she had deteriorated, and there was some improvement in neurological status in this particular dog, but eventually she was euthanized, not because of the intravenous lipid emulsion therapy, but because of her clinical status and the cost of therapy and the concerns that the owner had. So we don't really have a clear idea based on this case report as to whether or not bromethylene may have been more helpful if there had been subsequent doses, but there was some improvement in neurological status 24 hours after a toxicity. Would we expect that anyway? It's hard to say, isn't it? But that's the evidence that we have based on that case report. So when we're talking about bromethylene toxicity, we have one case that had significant decrease in concentrations of bromethylene in blood, and the patient did really, really well. And another patient that had intravenous lipid quite a long time after toxicity and showed a modest response. So what do we know from that about bromethylene toxicity and the use of intravenous lipid emulsion therapy? Probably if your patient is, critically unwell, maybe using it earlier, you may get a slightly better response. We don't really know at this stage. What about carprofen toxicity? There's a 12-year-old male-neutered cat who had an overdose of carprofen, had supportive treatment with activated charcoal and sorbitol, IV fluid therapy, pantoprazole, and buprenorphine, had some intravenous lipid emulsion therapy. Now, interestingly, serum carprofen levels increased at 1, 3, and 6 hours, and then began to fall afterwards. This increase is actually thought to be due to the movement of carprofen from the tissues back into the intravenous compartment or the serum compartment. So this is actually a positive thing, where this amount of drug is now moving out of the tissues back into the circulation where this intravenous lipid is, and then began to fall after the carprofen was hopefully excreted. This cat did develop azotemia at 24 hours after admission, but survived to discharge 5 days later. So this is quite encouraging here, particularly when we look at the pharmacodynamics of what happened to this patient's carprofen concentrations after intravenous lipid emulsion therapy. So there's potential there for non-steroidal anti-inflammatory drug toxicity that this may be helpful. What about cocaine? There's a case report we have in the veterinary medicine of a 6-month-old male entire dog. He had suspected illicit drug access on a walk. When you read the case report, it's interesting. The dog walks the dog interesting neighborhood. There was syringes and there was always unusual things lying around in the park that this dog walked on, and the dog didn't have any known access to illicit drugs, but did disappear behind the bushes and came out a little restless, bit agitated, developed pyrexia and hypertension in the vet clinic, was tachycardic and had mydriasis, and the urine test was positive for cocaine and PCP as well. The treatment involved meropitant therapy to decrease nausea, activated charcoal, and IV fluid therapy. But 6 hours later, the symptoms worsened in this patient. The patient became behaviorally really unpredictable, and tachycardia was worse. They administered intravenous lipid emulsion therapy, and this is too cool, okay? Recovery to normal mentation within 15 minutes. I'm saying this is a pretty positive response of intravenous lipid therapy in the use for cocaine or PCP toxicosis. Just going to backtrack a little bit. Got a great question from Anupam. Do we believe that the carprofen toxicity management improved due to the intravenous lipid, or was it just the IV fluid therapy and supportive care? That's a great question. And if I'm to be completely honest, we don't really know, do we? Except for the fact that the carprofen concentrations, if we just go back here, were measured at 1 hour, 3 hours, and 6 hours post-intravenous lipid emulsion therapy. So the lipid emulsion therapy did something. This cat had quite a large dose of carprofen. So what it would have done without the intravenous lipid therapy, I really don't know. And this is where, the use of controls and toxicity, we never like to deliberately poison a patient so we can get a control case and see what the difference is. But that's a great question. I would venture to say that potentially the intravenous lipid therapy might have helped, just because we've got serum carprofen concentrations that have been measured and they altered significantly after that intravenous lipid emulsion therapy. But that's just my take on it. But you raise a really good question. All right, what about diltiazem? This 4-year-old female spayed dog ate an extended release diltiazem tablet and presented 2.5 hours following that ingestion. She had an initial treatment of emesis, activated charcoal, and IV fluid therapy, but she became really bradycardic, developed atrial standstill and hyperglycemia, as well as hypocalcemic. Remember, diltiazem is a calcium channel blocker, but hyperglycemia is a known side effect of diltiazem overdose. Intravenous lipid therapy was administered when the patient failed to respond to atropine to increase the heart rate, as well as high-dose insulin therapy in order to decrease the hyperglycemia, and subsequently this animal needed glucose therapy as well. The response, pretty minor response from intravenous lipid emulsion therapy, so not that much. This was the single case report. This sort of protocol is used in humans as well to manage diltiazem overdose. The idea behind giving insulin along with the glucose there as well is to facilitate trans-cell membrane fluxes of calcium to manage the hypocalcemia. So, yeah, I really don't know if this patient did recover, but there was really only a fairly modest response to intravenous lipid emulsion therapy. When it comes to ibuprofen toxicity, we have a case report of the 3-year-old female spayed dog. She had CNS depression to stupor and obtundedness and coma within 3 hours of a massive overdose of ibuprofen. She was supported with antiemetics, prostaglandin analogs, so prostaglandin E. She had intravenous lipid therapy, which resulted in clinical improvement within 3 hours. So here we have a dog, again, that's had nonsteroidal anti-inflammatory drug toxicity, highly polar drugs, these are. Okay, they bind to proteins, highly protein-bound drugs. They are nonsteroidal anti-inflammatory drugs, and here they are responding to intravenous lipid emulsion therapy, both this and carprofen. So there may be a potential role for intravenous lipid emulsion therapy in managing these dogs. This dog was on supportive care for 3 days and then went home. What about local anesthetics? We expect an improvement in local anesthetic toxicity simply because it's when it was first described in people, it was a great response. What do we know about it in dogs and cats? Well, there's a case report of a 5-year-old malnourished cat with an accidental lidocaine overdose. This can happen, can't it? I mean, if you've got a patient who is very, very painful, they're having local nerve blocks, even a miscalculated dose goes in, and this cat had an accidental lidocaine overdose. The symptoms included lethargy, respiratory distress, variable pulses, severe hypotension, and development of pulmonary edema secondary to acute congestive heart failure. Treatment was with oxygen therapy and supportive IV fluid therapy, but they administered IV intravenous lipid emulsion therapy, and that resulted in to quote the case report, a dramatic improvement in clinical signs within a really short period of time, like we're talking 30 minutes or so. Now, this correlates well with what they observe in human beings that have local anesthetic toxicity, where the response can be dramatic. In that very first case described in 2006, a patient had cardiac arrest, they got intravenous lipid emulsion therapy, and they were able to be resuscitated. That would not have happened without intravenous lipid emulsion therapy. So bear this in mind if you've got local anesthetic toxicity. Loperamide, okay, it's an opioid. It's an kind of like it increases multi-haustral segmental contractions in the gut, so those mixing contractions in the gut, and decreases propulsive contractions in the gut. So it's used infrequently in people to treat non-infectious diarrhea. And this 8-month-old border collie had some loperamide to treat diarrhea for 3 days. And he had clinical signs of dull mentation, anxiety, tylism, and ataxia. He had intravenous lipid therapy administered. This is an opioid derivative, loperamide, and he was neurologically normal within 3 hours following the intravenous lipid emulsion therapy. Note, this guy was ABCB1 delta positive. Okay, so he had the genetic deformity of metabolism. This is possibly why he accumulated loperamide in circulation and developed these signs of opioid toxicity. So intravenous lipid emulsion therapy seems reasonably helpful in these cases. Now, there's a whole lot of macrolytic lactones, ivermectin, selamectin, all of the mectin cousins, they're all kind of in there together. What do we know about these drugs and the response of them to intravenous lipid emulsion therapy? Again, we've got a case report of a cat that ate an undetermined quantity of equine ivermectin paste. Can't you just see that? The ivermectin paste is the end of the tube's been left off. The cat's jumped up and gone, oh, this stuff tastes really, really good, and has had an undetermined quantity of it, presented to the vet, collapsed and hyperesthetic, so twitching, hyper-responsive to touch, had IV fluid therapy support, and that resulted in a worsening of clinical signs. So intravenous lipid therapy was administered at 24 hours following admission to hospital. There was an initial improvement noted after that bolus at about 30 minutes following intravenous lipid emulsion therapy, and then a marked improvement in 5 hours following a second dose of intravenous lipid emulsion therapy as well. So they gave one dose at 30 minutes and repeated another dose at 5 hours. Oh, sorry, no, they put her on a continuous infusion after the initial bolus, and by 5 hours she was looking much, much better. She had still some residual clinical signs of toxicity at 48 hours, so they repeated a dose following admission, and they got a notable improvement immediately following the intravenous lipid emulsion therapy. She went home 96 hours later with mild ataxia only. So this is a good outcome for this little cat. And what this shows us is that each time this cat received a bolus of received intravenous lipid emulsion therapy, there was some clinical improvement. So one might argue maybe the cat could have got another dose at 24 hours if it was non-lipemic, perhaps. And that may have led to a shortened disease course. But regardless, this cat had a good outcome. What about dogs? There was a 2-year-old female spayed dog that ingested another toxic dose of ivermectin horsewormer. Clinical signs Present at the vet were hypothermia, diffuse muscle tremors, and ataxia. Absent pupillary light responses and menace response as well was absent. Treatment with IV fluid therapy and supportive care. Intravenous lipids were administered twice, and there was improvement in clinical signs noted, and the dog was just discharged normal at 48 hours after admission. So look, with IV fluid therapy and supportive care, they didn't list too much in the way of supportive care in this particular case report. It was really IV fluid therapy, some methocarbamol to try to help reduce the tremors in the patient, and that was really about it. But the notable thing was that clinical signs improved after intravenous lipid therapy was given to these patients in a relatively short time frame. All right, now another case report here. This was of 3 cases, all of whom were ABCB1 delta mutation positive. Okay, so these were all collies, I believe, and all 3 dogs had naturally occurring ivermectin overdose, and intravenous lipid emulsion therapy had no impact on clinical signs in all 3 of these dogs. So if you're ABCB1 delta mutation negative, then chances are with a macrolytic lactone that you're probably going to have some response to intravenous lipid emulsion, but you may not have if you've got ABCB1 delta mutation positive. Good question from Maria here. She just said, are there any contraindications to using methocarbamol and intravenous lipid emulsion simultaneously? Look, I think when you're giving multiple drugs intravenously, either you need to flush one catheter if you've just got a single catheter in, and make sure that catheter is flushed with saline before you give your dose of methocarbamol, or you can put another IV catheter in if there's concern. I'm not aware of, certainly there's no contraindications to their mechanism of action. They act in a completely different way, but whether or not the solutions are compatible, certainly if you're using intravenous lipids for nutrition, they recommend that you don't use anything else with them, but that's predominant in the same catheter, but that's predominantly due to wanting to reduce the risk of contamination of your intravenous lipid line, because intravenous lipids will provide bacteria with a great substrate for growth, and so you want to keep these IV lines really nice and clean. All right, let's have a look at the next one, marijuana. Here's a case report, 2-year-old male and tired dog that presented following exposure to synthetic cannabinoids. These are becoming more and more common. The dog presented with clinical signs of ataxia, hypothermia, sinus bradycardia, stupor, intermittent aggression. So this dog was really not having a good time. Progressed to coma and intermittent apnea within 2 hours of presentation. So this patient deteriorated clinically in a very, very profound manner. This dog required oxygen therapy, intravenous fluids, and ventilation therapy in order to manage the intermittent apnea that was present. Intravenous lipid emulsion therapy was administered as a bolus and a continuous infusion for 6 hours, and the dog actually appeared to recover fairly well. Now, marijuana in theory should be a drug that will respond pretty well to intravenous lipid emulsion therapy, and this seems to be supported by this case report, but we really only have the one case report in dogs to go on. There's just not that much published. Naproxen. Wow, lovely naproxen. Okay, so case series of 3 dogs. Okay, they had 50 to 70% reduction in naproxen concentrations within 1 hour, 75% reduction from baseline levels at 3 hours following intravenous lipid emulsion therapy. Other treatments in these patients included emesis fluids, GI support, activated charcoal, and gastric acid suppression, and so on. So it's unclear whether the reduction is due to the intravenous lipid emulsion therapy or that this was just due to the standard care that was given, but naproxen is highly lipid soluble, so there is potential for intravenous lipid therapy to be effective. in these situations as well. So this is yet another non-steroidal anti-inflammatory drug that we have potential to be able to use intravenous lipid emulsion therapy in. Organophosphates and carbamates, there were 2 cases in the literature. Carbamates had a good response to intravenous lipid emulsion with a rapid return of normal neurological function. It's fair to say, though, I have to say, that if you've got an intestinal or an ingestion of carbamate, nothing really beats gastrointestinal decontamination. Okay, so do your gastric lavage, do your repeated enemas in these patients. If you have an oral carbamate toxicity or an ingested carbamate toxicity, make sure you are removing this drug from the gastrointestinal tract. By all means, if you want to use intravenous lipid emulsion therapy, then yeah, you can use that. But don't forget your standard of care, which is gastrointestinal decontamination. If it's a dermal exposure, then by all means attempt this. Now, permethrins, see that at the beginning of the lecture there were a couple of people who'd used intravenous lipids for confirmed permethrin toxicity in which it was known. In the literature, there's a case report of a 7-month-old male entire Cavalier King Charles Spaniel. He had accidental permethrin containing cleaning product ingestion, and he was presented with muscle tremors and intermittent seizures. Prior to veterinary examination, he had supportive care, and he had intravenous lipid emulsion therapy administered, and he had cessation of tremors that coincided directly with his intravenous lipid emulsion therapy. We don't have to worry about intralipid absorbing to other drugs. Oh, Claire, you're brilliant. Because that can happen, and I'm going to talk about that just as we end the lecture in a few minutes' time. Because we're up to P now, aren't we? So we're nearly at Z, and then we're going to talk about some complications. The short answer to your question is yes, the intralipid can absorb some of the therapeutic drugs that you're giving your patient. But I'm going to talk about that in a second. Phenobarbital. Mild improvement in a single, actually the ASPCA Animal Poison Control Center and Tox database, unpublished data. This was information that I got off a review. There was a mild improvement in clinical signs reported, and I see that somebody had said they used it in a barbiturate toxicity before, and that they had a reasonable response to it. And that seems to be that there is a bit of improvement in clinical signs. What about tremogenic mycotoxins? There was a great review of 53 canine cases here in dogs with suspected tremogenic mycotoxicosis. 96% of them had a clinical improvement following intravenous lipid emulsion therapy, and the median time for clinical improvement was pretty short. 4 hours. There were no adverse effects. This is a lovely case series. So tremogenic mycotoxins, intravenous lipid emulsion therapy seems to be great for these. Now, I've seen patients with tremogenic mycotoxins before intravenous lipid emulsion therapy became a thing, and some of these patients are still shaking despite me doing 5 or 10 enemas in a 12-hour period to try and get decontamination of the gastrointestinal tract, repeating a gastric lavage, in 6 hours afterwards, just to make sure that there wasn't anything in the stomach from reverse peristalsis, which can occur. I've seen patients with stomach full of metaldehyde or carbamate toxin in their stomach, even though I have had an empty stomach following gastric lavage, and 6 or 8 hours later they've had a stomach full of it because it's reflux from the duodenum back into the stomach. So tremogenic mycotoxins, make sure that you're doing gastrointestinal decontamination. I can see Anupam's excited because it's one of the most common toxicities she sees that's so good for mycotoxins. Yeah, absolutely. This is fantastic news for this patient. So are there any risks? I probably should have renamed the slide. Are there any downsides to managing a patient with intravenous lipid emulsion therapy? Well, there's potential for an anaphylactoid reaction, but honestly, there is really nothing reported in the veterinary literature. There is a very small number of cases in human literature where people have a mild increase in heart rate. They get hypotension. The infusion is stopped. They have a mild anaphylactoid type reaction. This is a big one, potential, okay, with these solutions. And Anupam, just before the lecture started, asked if I could talk about intravenous lipid emulsion therapy to manage malnutrition or to provide nutritional support in hospitalized patients. And honestly, if you're using intravenous lipid emulsion therapy, lipids will provide a great source of nutrition. Intravenous lipid will provide a great source of nutrition for bacteria. And these solutions need to be discarded once the bag is broken. Okay, within probably 6 to 8 hours, I'd be throwing the bag out. Okay, if you've got one of those multi-dose small vials, use it for one patient. Don't keep it. They don't have preservatives in them. So once they're broken, we really need to think about discarding the solution. So bacterial contamination of the solution is a big thing. If the solution is not squeaky clean and white, okay, don't use it. If it's looking a bit pink or if it's looking a funny color, then don't use it. Okay, it's got to be nice and white. Lipemia is a potential adverse reaction, and along with this is lipid emboli. So the lipemia really is a precursor to lipid emboli. There's lovely pictures of lipid emboli in these patients. Well, I say lovely, not for the, it's a histology slide, so things may not have gone too well. But yes, you can get lipid emboli in your any vascular bed. You could potentially get thrombosis in the kidneys. You could potentially get thrombosis in the GI tract, the liver, the heart, the lungs, the brain, the muscles, anywhere in the body. So this is something to be concerned about. This is one of the reasons why we don't like to administer subsequent doses of intravenous lipid when patients are lipemic. Okay, so make sure you do make sure you are taking a PCV total protein and examining the serum plasma layer before you administer subsequent doses. I see a question there. Can you cause a GDV by rolling the dog for lavage if they're a big breed of dog? There is nothing published on that. And I would venture to say, if you look at big breed dogs, many of them lie on their side and they roll on their back and they scratch themselves on their back and then they roll over to the other side. And most of them don't get GDV unless you're a Great Dane, and then in case you've got a 40% lifetime chance of getting a GDV. But if you're just a big dog, then rolling a patient upside down, even though they're slightly more relaxed under anesthesia, doesn't seem to increase the risk of them getting gastric dilatation volvulus. And, maybe in theory it might, but it's not something that's appreciated. And certainly I couldn't find anything in the literature about that. There's potential treatment failure. So intravenous lipid might not bind the drug that you are trying to treat, and that's certainly a possibility. There are many hundreds of drugs that we haven't talked about tonight, but also intravenous lipids will bind benzodiazepines like diazepam and midazolam. So if you're using these drugs to manage seizures in your patients and you administer intravenous lipid emulsion therapy, your benzodiazepine may not work as well. So you might need to repeat the dose or increase the dose or change to another drug. You might also get reappearance of clinical signs as well if the duration of action of your drug is longer than the duration of intravenous lipid emulsion therapy existing within your patient's bloodstream. Intravenous lipids can result in a suppression of the immune system, so use them with care. If you have a patient that is untreated Cushingoid patient or a patient who has other significant disease, if you've got a patient on immune suppressive therapy, a patient on chemotherapy, then intravenous lipid emulsion therapy can further suppress these patients' immune systems, and so you may need to just monitor these patients with additional vigilance when it comes to potential for them developing infection afterwards. Now, the two things that I have written here, fat overload syndrome and volume overload syndrome, are really part and parcel of the same thing that I mentioned right at the start of this session, and that is intravenous lipids will cause hypervolemia. And so particularly if you have had cats or if you have dogs with heart failure, or if you have a patient who perhaps presents or who has had significant volumes of intravenous fluid therapy, or patient who has perhaps aspirated because of the toxicity that they've had. They've vomited and aspirated. They may already be developing pulmonary edema, and we administer them intravenous lipid emulsion therapy. Just be aware that maybe you might want to slow down that rate of the initial bolus from that sort of 10 to 15 minutes, maybe administer that bolus over half an hour to an hour, or maybe just put the patient on an intravenous lipid emulsion continuous infusion. Oh, great question. Would we recommend testing cats for FIV before starting intravenous lipid emulsion therapy? There isn't a firm recommendation on that. My thought on this, and I'm thinking on my feet here because I haven't actually thought about that before. So I love your question, Maria. Thank you so much. My thought is that if I had a cat that had a toxicity that was going to result in significant morbidity and perhaps mortality, even if that cat had FIV, I probably would, if it had the potential to recover after intravenous lipid emulsion therapy, I'd probably be inclined to go ahead and give it, and just to monitor that patient. Maybe if the patient shows early signs of urinary tract infection, or if they got respiratory symptoms or whatever, maybe I might choose to put them on antibiotics if they started to show signs of infection. And I wouldn't put them on any special antibiotics. I'd put them on just a beta-lactam antibiotic like amoxicillin or something like that. I wouldn't put them on triple antibiotic therapy until I actually had something to culture. Otherwise, what I'll do is, if I start them on multiple antibiotic therapies because they're immune suppressed, what I'm going to do is I'm going to wipe out loads of bacteria and leave the ones that my good antibiotics, or the ones with extended spectrum or specialized spectrum, I'm going to wipe out bacteria that those antibiotics kill, and I'm going to leave antibiotics that are resistant to the antibiotics that I've just chosen. So just start with your frontline antibiotics if you're going to use them. Great questions. So what do we know about intravenous lipid emulsion therapy? In truth, I'm sure you can agree with me that when you look at the literature we have in veterinary medicine, there's 1 or 2 or 3 cases, apart from tremogenic mycotoxins, in which there's a great number of cases for a veterinary study. But everything else, there's not that many animals that we have to go on when it comes to knowing whether or not, A, the patient's going to tolerate the medication, secondly, what its response is. We have no double-blinded crossover double-blinded clinical trials. We have no controlled clinical studies on intravenous lipid emulsion therapy. A lot of what we're using this medication for is based on extrapolation from human medicine. And I think as long as we're aware of that, I think we can make some sound and rational decisions regarding therapy. So, there are a number of highly polar molecules that have been successfully managed with intravenous lipid emulsion therapy. And I'm thinking about, in particular, the non-steroidal anti-inflammatory drugs that are highly protein bound. We also see highly lipophilic drugs as well that respond very well to intravenous lipid emulsion therapy. So there's a range in between. So it's not necessarily the old paradigm of it has to be highly lipid soluble for it to work. So that is really what I had for you today. Have I used it in metaldehyde toxicity in dogs? No, I haven't, but I would expect that there may be some potential. My standard treatment for metaldehyde toxicity is empty the gastrointestinal tract as much as you possibly can, and most of those patients will go home within sort of 12 to 24 hours if you are really, really vigilant with your gastrointestinal decontamination. Some of them might stay in your clinic for 24 or 48 hours if they've got really severe neurological signs when they present to you. But I've treated thousands of those patients with metaldehyde toxicity, and I'm not lying to you. We used to see about 10 cases a week where I used to work, and so these, there's 500 cases a year. So most of these patients with metaldehyde do recover. I think with the residual clinical signs that you see, as long as you're doing gastrointestinal decontamination, you could try giving it and see if it was effective at all. Now, good question. Even at toxicity treatment dose, is there a risk of pancreatitis or liver disease with intravenous lipid emulsion therapy? In theory, persistent hyperlipemia could potentially cause some pancreatic cell damage. And this is one of the reasons why we don't like patients to be lipemic before they get their second dose. And the same would go for liver disease as well, particularly in cats, because they don't metabolize lipids all that quickly, or certainly not as quickly as dogs, and fatty liver could potentially cause some liver damage in cats. So yeah, for sure, I think there is a potential risk for those patients. So always check the patient for lipemia before a subsequent dose, and if they're lipemic, then the recommendation is to delay the next dose. And when you think about it, if your patient's still lipemic, they probably still have the lipid in circulation, right? So why are we giving them a subsequent dose if they're still lipemic? So that kind of makes sense to my way of thinking. I want to thank you guys for your amazing questions and participation this evening. I hope that I've been able to answer at least some of the questions okay for you. This lecture has been brought to you, just finished off talking about our course that sponsored this lecture, the Venoms and Toxins in Small Animal Practice. It's a 4-week online course. It's race approved for 20 CPD points. It's been written for veterinary nurses and technicians, but if you're a vet and you want to take part in the course, you're more than welcome to do so. And we do provide extra information for both veterinary nurses and technicians, but also veterinarians if you want that extra information. There's practice protocols, tutorials, extensive course ebook that covers a ton of toxins there and updates. If you register prior to the course starting, we give you free infographics. There's a free ebook on sedatives and toxicity in patients, and you'll also be able to download the recording of this lecture as well. So happy to take any more questions from you, and I can't promise to answer all of them with a whole lot of science, because we don't have the information. So I see there's a couple of questions. If it responds well to, if marijuana toxicity responds well to intravenous lipid, do we think it might work for lily toxicosis or any other plants? Have I used it? No, I haven't. But because lilies and cycad toxicities are such rotten toxicities, I'd be really keen to find out whether or not it may be of some value in some of those awful plant toxicities that we deal with. Because, to be quite honest, if you've got a cycad toxicity patient, I mean, they're hard work, right? And if you've got a little puppy that's come and has eaten a cycad plant, it is really sick, and there's anywhere between a 20 and 50% chance that dog is going to die from its toxicity. So if we had something that we could add into our treatment regime, I think that'd be brilliant. But I don't know the answer. I'm just very excited about the possibility. Toxic mushroom ingestion. Would the potential there be that intravenous lipids might work? There is a possibility. I know that the mycotoxins are sort of fungi, aren't they? So there's a possibility that it may work. Again, I really don't know. Again, your guess is as good as mine in some of these toxicity as well. How long does it take to clear the lipid from the body? Look, that's a really good question as well. In the studies that I read and that we've been through tonight, it seemed that some animals were lipemic 24 hours after they had their first dose. So it can take quite a long time, and I guess some of it is going to be determined by what else is going on in that patient, what else they're having to metabolize at the same time, and what other medications you're giving them too. Now, would I use intravenous lipids in a suspected toxicity if the patient's otherwise healthy? By healthy, I'm guessing that you mean that they're not seriously obtunded. Look, I think this really comes down to what do we do for patients in which we really don't know what they've had, right? And do we administer intravenous lipid emulsion therapy to everything in case it has a toxicity that it might be responsive to? And I'm inclined to think about toxicities in a similar way to the way that they do in the emergency department in hospitals, and that is that, frequently you've got no idea what the human patient has been intoxicated with. You can run a tox screen in urine, but there could be anything, and the symptoms the patient is showing can really kind of give you a bit of a clue as to what you might be dealing with, and that might help steer you down the line of whether or not you use intravenous lipid emulsion therapy. So if you've got anticholinergic signs, okay, so you've got really dilated pupils, and patients that have got really thick tenacious mucus at the back of their airways, they've got central nervous system disorders, then some of those patients will have ingested a toxin that may be potentially responsive to intravenous lipids. So look, if the patient is conscious and you're able to make them vomit, see what's in the vomit, see what's there. If not, then maybe do an enema, see what comes out the rear end. Oftentimes we find in our toxicities that we find this sort of non-specific organic semi-vegetative matter. There's sticks and some leaves and some other greeny browny stuff that doesn't look like anything that someone's put on their garden. So this dog might have eaten feces, it might have eaten a decomposing animal, it might have eaten anything at all. And in some of those patients, particularly if they have central nervous system signs, then there's a good potential that some of those patients will be responsive. But I wouldn't be using intravenous lipid therapy as necessarily a frontline. I'd probably want to know a little bit more about potentially what that animal has had, and then to administer intravenous lipids if my patient A, wasn't responding all that well, and secondly, if they had symptoms that might cause me to believe that perhaps they might have a toxin that could be responsive to intravenous lipid. I know that's the least committed answer you've probably heard tonight, but if the patient's had anticoagulant, probably not going to use that. Okay, if they've had got cholinergic signs of pesticides and so on, then yeah, sure, I might use them. If they're convulsing, then yes, I might use them. If they've got clinical signs of opioid toxicity, yes, I might be inclined to use intravenous lipid emulsion therapy. So those are the kind of ways I like to think about things. Christina, great question. I love it. How long does it take the lipid emulsion to be eliminated from the patient? I think it varies, as we mentioned before, but when do we feel comfortable that we're unlikely to have interactions with other therapeutic medications? Probably once that lipemia disappears from circulation, if you know what I mean. So because that's a sign that the serum concentrations of lipid are starting to decrease. And that is probably the best information that we have so far to enable that clinical decisions. Are we using intralipid as a standard protocol for any non-steroidal toxicity or just in selected cases? I think, again, great question. If I can be so bold, if you have a patient with severe toxicity with non-steroidal anti-inflammatory drugs, I would be inclined to administer intravenous lipid emulsion therapy earlier rather than later, simply because I don't want a patient to develop acute kidney injury, right? So I think that we've got some clinical case evidence that it could be really beneficial in some of these cases. So as long as, again, you're doing your standard decontamination and you're looking after the GI tract and everything else, I think that it's a fair call. Would it affect levels, or would intravenous lipid affect levels of some of the anti-parasiticide or some of the parasiticide treatments that we give to our patients? Potentially, they could. How often do I see lipid emboli? Any stats or any studies, and what dose? That can be seen at the standard dose that we've just mentioned. There aren't any studies. It's really just described in people. But I love the comment that you've made there, Anupam, that cats with cardiac disease, if they have got smoke in their left atrium, or if they've got little small microemboli that are sitting in the left atrium ready to be fired around the circulation, and you give them a nice bolus of intravenous lipid, you could end up with some blood clots and some lipid emboli. It's certainly a possibility. So cats with left atrial dilatation, yeah, maybe that's something that we need to be careful about in terms of giving this, because that might increase our potential. Wow, what great questions you guys have had. I really loved spending this evening with you. I know I've gone a tiny bit over time, but this has been the Intravenous Lipid Emulsion Therapy in Small Animal Practice lecture, brought to you by Venoms and Toxins in Small Animal Practice. Of course, check out the website veteducation.com.au for more course details. Danielle's just put your certificate link up there for CPD certificate points if you need them. Thank you so much again for coming along tonight, and we hope to see some of you on the upcoming course. Thank you and good evening.